The cardiac cycle is regulated in response to changes of volume of blood that are flowing into the heart and the control of the heart rate and also the strength of the autonomic nervous system. So there's a couple factors that we'll look into that help with this regulation process. From an intrinsic standpoint or from a heart regulating itself standpoint, we have our Frank Starling mechanism. This is essentially saying what goes into the heart must be pumped out. The amount of blood pumped into the heart every minute is determined by the rate of blood flow in the heart from the veins, or AKA venous return. The ability for the heart to adapt to increasing volumes of blood is how the Frank Starling mechanism works. So if there's the more the heart muscle is stretched due to filling, the greater the force of contraction, greater contractility must be, and therefore the greater quantity of blood pumped into the aortic, which then would match the blood that was essentially drained in initially. So when extra blood flows into the ventricles, cardiac muscle is stretched more. Um, when cardiac muscle is stretched more, this causes muscle contraction to occur with more force. When that happens, the actin and myosin filaments are actually brought to the optimal degree of crossover or overlap for force generation. The ventricle then pumps excess blood into the arteries. How can we look at this from a math perspective? Looking at this exact same thing, we have some definitions. End diastolic volume is the end of essentially filling. This is our preload, right? So how much blood is in the heart at the end of diastole. And systolic volume is inversely related to contractility, how much blood is left over after each pump or ejection. And then stroke volume is end diastolic volume minus end systolic volume. So what was in there for filling and minus what was ejected, and that's going to be stroke volume. Injection fraction then takes stroke volume and it divides it by end diastolic volume. So all of these pieces are kind of showing these interrelationships between these components. Now, how can stroke volume be varied? What can vary stroke volume? Well, preload can affect stroke volume. If we have increased venous return, increased blood coming back into the heart, our end diastolic volume would be greater, and that's essentially meaning preload will be greater, which will increase stroke volume and contractility. Now, if on the inverse effect, if we have, look at afterload, if afterload increases because we have increased total peripheral resistance, we'll have increased end systolic volume because blood will have a harder time leaving the heart, therefore less stroke volume. Preload in this instance would compensate in a healthy heart. We'd just bring more blood back into the heart. Afterload will have a much more dominant effect in a heart that is failing. The law of Laplace talks about wall stress and how walls start to get stressed out when in heart failure, for instance. And it's related to the pressure inside the chamber times the radius of the chamber divided by wall thickness. And that's related to or equal to wall tension divided by wall thickness. So wall thickness has a great deal to play, that hypertrophied ventricle. We can see here for contractility that if we have increased sympathetic nervous system activity, that's going to lead to increased contractility. Sorry, my little arrows didn't translate over when I copied and pasted, which is going to lead to decreased end systolic volume, which is going to lead to increased stroke volume. So this is kind of looking at our contractility equation. So preload and contractility, if they increase, stroke volume increases. If afterload increases, stroke volume decreases. Tying this back to the Frank Starling mechanism, if we increase preload, we increase contractility, we increase stroke volume. Because if we increase venous return, then we have more end diastolic volume. That is more preload. That means our myocytes are stretched more prior to contraction, which means our sarcomere length is bigger, larger, which means there's more active tension, and then there's more velocity when the fibers finally do shorten. Now, if we relate this to cardiac output is heart rate times stroke volume. We can look at this from the Fick principle. Cardiac output is the rate of oxygen consumption divided by the arteriovenous oxygen difference. And so we can relate this between these two different variables, how fast the heart is beating and how much blood is ejected, and then how much oxygen is being used versus what is the difference between oxygen content in the arterial system and the venous system. We can start to then pull in kind of how systemic blood flow affects these different variables happening within the heart. So total peripheral resistance is determined by the state of our arteriolar resistance, the resistance within our arterioles in our body. Pulse pressure is looking at the difference between systolic and diastolic pressure. For instance, if we had 120 and 80, we'd have a pulse pressure of 40. Mean arterial pressure then is looking at cardiac output, so how much blood is ejected every minute, times total peripheral resistance. And then we could take that a step further. We could say mean arterial pressure also is 1/3 of diastolic pressure divided by 2/3 of, or 1/3 of systolic pressure divided, or plus 2/3 of diastolic pressure. We also could say that mean arterial pressure is 1/3 of pulse pressure plus diastolic pressure. All these things are the same way of measuring mean arterial pressure, which means that we can utilize different interrelationships. The autonomic nervous system's control of the heart is using, our sympathetic nervous system, and this leads to increased cardiac output, increased amount of blood pumped each minute. The idea is to increase the heart's rate and force of contraction, which increases the volume of blood and the injection pressure, versus our parasympathetic stimulation leads to decreased cardiac output. There's a minor decrease in strength of heart muscle contraction, but it doesn't really innervate or affect heart muscle contraction. It's really majorly decreasing heart rate. And our vagus nerve fibers are distributed much more to the atria than the ventricles. They're really much more affecting the SA and the AV nodes more than the actual ventricle fibers themselves. Now, we do have some ions effects on kind of control over the heart. Uh, when we are dealing with potassium ions, if we have extra potassium ions in the extracellular fluid, it'll lead to a floppy, a dilated, a flaccid heart, which will slow down the heart rate. Excess can also sometimes fully block conduction of the electrical impulse from the atria to the ventricle. Because we have a decrease in resting membrane potential, it's less negative. Therefore, it's a decreased intensity of the action potential and a decreased heart muscle contraction. Versus our calcium ions, if we have excess calcium, it causes the opposite effects. It leads to a spastic contraction because calcium initiates the cardiac contractile process. If we had a decrease in calcium, it can lead to cardiac weakness, which looks similar to high potassium. Temperature, when we have an increase in body temperature, that's going to increase heart rate and vice versa because heat increases permeability of our heart muscle membrane and makes the ions that control the heart rate essentially be able to move more freely in and out of spaces, which increases the self-excitation process seen from the conduction system. During exercise, the heart strength of contraction is temporarily increased with moderate temperature increases, and a delayed moderate temperature increase will eventually provide weakness of the heart. And this is due to metabolic needs. We run out of the metabolic needs to continue to keep that metabolic rate going. So temperature directly affects the rate of ion leakage into the SA node. So if we have a higher temp, we see this SA node firing faster, which means an increased heart rate or a positive chronotropy. Versus if we have a decreased temperature, the SA node fires slower, a decreased heart rate or negative chronotropy. If we have a rise in core temp during exercise, that also can contribute to the increase in heart rate. And this is one of several mechanisms, along with our sympathetic nervous system being stimulated during exercise, that drives exercise-based tachycardia or exercise-based fast heart rate. In a hypothermic state, we'll see slowing of ion transport across the SA node membrane, which leads to bradycardia or slower heart rate. In really severe states, less than 30 degrees Celsius, this could lead to a life-threatening arrhythmia like a VFib or VTAC. You can use therapeutic hypothermia deliberately after a heart attack, cardiac rest, to decrease metabolic demand on the brain, essentially slow down the body's metabolic needs. In hyperthermia or fever, every 1 degree Celsius rise in body temperature increases the heart rate by approximately 10 beats per minute. If you aren't seeing that, if you're seeing a high temperature but not an appropriately high heart rate, then there's something potentially going on. Your body might be going into shock. The mechanism behind this is you're having an increased metabolic rate of your SA node cells, which is going to increase or accelerate the spontaneous depolarization process. You expect then tachycardia in fever patients, and it's physiologically appropriate. So if you don't see that, you should be concerned. I think what we'll do is we'll come back next and we'll talk about the conductive system of the heart. We talked a lot about a lot of math.